Well, I feel compelled first to make just two clarifications. Number one, our expenditure on healthcare today stands at 4.6% of GDP. I agree it is less than what we should have, but it is not 2-point-something%. The second issue is Dr. Rono has mentioned the leading cause of mortality in the country, malaria. In fact, the third leading cause of mortality is cancer. And this is after infectious disease and cardiovascular diseases, meaning that cancer and cardiovascular diseases are number 2 and number 3 in terms of causing mortality in Kenya today. We are talking about 27,000 people dying of cancer every single year, something that in the Western world, they're having significant reductions in mortality. Now, why am I talking about treatments like cancer? Because in the context of primary versus tertiary versus secondary, the matter of cancer treatment lies in tertiary care. The matter of neurosurgery lies in tertiary care. Any kind of surgery that you require lies in secondary tertiary care. When you talk about dialysis, it's tertiary care, ICU, tertiary care, the basics of life that people need today. These are not in primary care per se, they're in secondary and tertiary care. Yes, primary care is important, but primary care is not what is driving families into poverty. The biggest part of my presentation today is that we have to go back to the basics, the fundamentals. The fundamentals are this. We are addressing UHC. And what is UHC purposing to achieve? Number one, that all individuals in the community access the healthcare that they need. All. They access the healthcare that they need. Should we say that we are giving UHC if when you need dialysis, you cannot get it? Can we say that you are achieving UHC if you need cardiac surgery, you cannot get it? Can we say that if you need a specialist, you cannot see that specialist, and we call that UHC? The first answer to that question is no, that is not UHC. That is some level of care that focuses on volume as opposed to quality. I said that in my introductory remarks. Today in our country, we have patients who are being treated over and over again for malaria and typhoid for months, and they have cancer. Why is that? Because the processes of diagnosis, the processes of access to a healthcare person who is able to make those decisions, it's not there. It's limited. In fact, I want to tell you, as much as you're arguing about UHC, in this country today, we have some form of UHC. Our public facilities are actually financially accessible. Many of our health centers, you pay 50 shillings, 100 shillings. Most families can afford that. I agree, there are many families that do not afford it, but in fact, most families can afford that. What they cannot afford is a situation where you need to invest massively in healthcare. All of us have been part of fundraisers, trying to meet a hospital bill, trying to get a loved one into a space where they can get healthcare. Many families today have to make a decision between good healthcare or just taking the healthcare they can afford. This is our reality, and we have to change that. And therefore, my view is that for us to impact society, to achieve the real vision of UHC, then the government has to make these services available. Unfortunately, only 8.7% of Kenyans are able to access voluntary insurance schemes, and a further 9.9% are getting insurance through the social scheme. These numbers are paltry, and it's because a big majority cannot afford either the social scheme or cannot afford the voluntary scheme. What can we do as government? Make healthcare responsive and accessible. We've spoken about us not being in isolation in the global village. The current situation is one of the best examples of UHC is the British system, the national health system. And in that system, two things happen. Number one, they actually cover every citizen of the country. And number two, they get all access to all levels of care. If you need surgery under NHS, you're going to get it. If you need cardiac review, you're going to get that. A specialist, you'll get it. Why should we say there's a standard of healthcare for Africa which is poor? You can't have a cardiologist, you can't have dialysis, you can't have surgery. Yet in Britain, you can have surgery. Why do we say UHC for Africa is different from UHC for Canada, UHC for Japan, UHC for Britain, where all these things are possible? And then finally, ladies and gentlemen, let us not confuse UHC versus the mode of payment. What my colleague is talking about is what is called a sort of a social healthcare scheme where the government is paying. It doesn't have to be that way. We are not talking about a single payer system. We are talking about a system where it is funded, yes, but everybody has access without facing financial hardship. I put it to you today that it is not paying for the headache in the center that's going to make you face financial hardship. It is having to pay 100,000 shillings a day in ICU that's inaccessible. Thank you very much.